You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech and Finding Genius podcast. My guest today is Sharmila Anandasabapathy. She's a doctor, a professor of medicine and gastroenterology, director of the Baylor Global Initiatives and the Baylor Global Innovation Center at Baylor College of Medicine in Houston. And we're going to be talking about her work. So Sharmila, thank you for coming.
Thank you. It's a pleasure to be here.
Yeah, so if you don't mind, in summation, what's your work about? What's it about currently? And then we'll go a little bit into the background.
Yeah, so there's two broad areas that I focus on. One is gastrointestinal cancers, and specifically gastrointestinal cancer prevention, focusing mostly on esophageal cancer and stomach cancer, and the development of lower cost, portable diagnostic technologies that can be used in very variable global settings to provide early detection of esophageal and gastric cancer. And in this area, we also look at, computer-assisted diagnostics and augmented reality for both training and early detection. Our focus is on imaging. And my second focus, partly because we work in under-resourced areas of the worldwide, is that I run our global health programs and look at the development of different technologies and approaches for addressing some of the leading challenges worldwide in terms of healthcare.
So why esophageal and stomach cancer? I mean, there's many kinds of cancer out there, but what in particular draws you to this area?
So because the reason that's my specific research focus is because I'm a gastroenterologist, and esophageal cancer actually is one of the highest rising cancers in the world. There's two different kinds of it, but the one that's rising the most rapidly is due to acid reflux disease. There's a second type of it which can be due to nutritional deficiencies and also environmental effects, alcohol and smoking. Both types of cancers are prevalent worldwide, and even more importantly, when they're diagnosed too late, the mortality rate from this is very high. Stomach cancer is also very common globally. It's one of the top 5 cancers in under-resourced global settings. It is typically due to a bacteria, and this is also a leading cause of mortality, particularly in lower resource settings worldwide. So it's an area of interest to me, and so the combination of technology, imaging, and training the clinical workforce to be able to find those cancers and treat them has been the area of my work for over a decade.
You said that stomach cancer, one of the reasons for it is a bacteria. Can you talk about that a bit?
Yeah, there's a bacteria called Helicobacter pylori, which is common actually worldwide. It's probably present in probably 80% of the population worldwide, and when it colonizes the stomach, it creates inflammation. It can actually lead to ulcers in the stomach. It can lead to bleeding from those ulcers in the stomach, and it can cause changes in the stomach, in the lining of the stomach, that eventually can lead to cancer in a small minority of patients. Not in everyone, though.
Okay, and then you mentioned acid reflux. Is that directly attributable to the rising level of stomach cancer or stomach cancer itself, or is that just appear to be, coincidental? I mean, what do you in your estimation, what do you think are the drivers of the increase in stomach cancer, for instance?
Yeah, so stomach and esophagus are completely different, and in fact, they segregate in very different areas of the world. So in parts of the world where there's high rates of stomach cancer, you don't actually see a lot of acid reflux-related cancers. And in areas of the world where there's high rates of esophageal cancer, you often don't see high rates of stomach cancer. So the acid reflux-related cancer is due primarily to increasing prevalence of the Western diet, weight gain, and obesity, which directly contribute to increased acid reflux, and a condition called Barrett's esophagus, which you may have heard of. Barrett's is a sequelae of chronic acid reflux disease, and Barrett's esophagus is the primary precursor to esophageal adenocarcinoma, which is one of the highest rising cancers in the Western world.
So, what are some of the early signs that someone will have, either esophageal or stomach cancer? What will they experience?
Yeah, a little bit different, but there's some overlap. So esophageal cancer is often hard to diagnose until a patient develops difficulty swallowing. Prior to that, a patient may have experienced, acid reflux, heartburn, regurgitation over a period of years. If they come in to see a gastroenterologist, often they will be scoped, and if Barrett's is diagnosed, they're scoped at regular intervals, usually 3-year intervals. And for patients who are in so-called endoscopic surveillance, where they're scoped regularly, there is a lower rate of progression to cancer. But the patients that we do see with cancer have usually not been scoped, and they've had acid reflux disease for years, and their Barrett's was not diagnosed. And those are more advanced cancers, and when the cancer is diagnosed at an advanced stage, and what I specifically mean is that it's reached the superficial lining of the esophagus and gone into the wall of the esophagus. So it's not in the paint, it's gone into the sheetrock, if I can use an analogy. Then there's an increased likelihood of involvement of the lymph nodes and the vessels, and the cancer is more advanced and the mortality rate skyrockets. Now, if the cancer is diagnosed when it's in the paint, superficially, the survival rates are well above 97%, and it can be treated through an endoscope, which is a huge difference. Now, similarly, stomach cancer is also another cancer which really should be diagnosed when it's superficial, again, in the paint and not in the sheetrock. The symptoms are quite different. Patients with stomach cancer often are undiagnosed, but sometimes they develop abdominal pain. They may have difficulty eating a full meal. They get full quickly, and often they may present with anemia, lower levels of GI bleeding from the tumor. This can happen with both esophagus and stomach, but both of those cancers are very, very difficult to diagnose unless a patient undergoes endoscopy, and endoscopy is really the only way of diagnosing them early. And because of that, that's why my group has really focused on developing endoscopic tools and technologies that can be portable, that can be battery operated, that can be used by non-experts, and that can be used in lower resource settings of the world so that people can be screened for these cancers, even in areas of the world where they can't afford standard endoscopy, like in the United States.
So what are some of the innovations in treatment that are going on right now?
Yeah, so what we have been looking at, and we have taken it to clinical trial in some settings worldwide, are kind of portable endoscopes or portable microscopic endoscopes. These are tools that can work off of a cell phone or a tablet, and they can image the wall of the esophagus, and they can magnify the lining of the esophagus. I should actually add the esophagus or the stomach to about a 1000x level of magnification. And when you do this, what you can actually see are the cells in the esophagus and the stomach. You can see a 1 millimeter area, and you can actually distinguish cancer from the normal tissue and see that cancer in real time. And our goal is not necessarily to look for advanced cancers, but our goal is to look for some of the early superficial changes suggestive of precancer, or a very early cancer that is in the paint, again, not in the sheetrock, but in the paint. so that we can actually treat that precancer or cancer through the scope at the point of care.
Well, again, how do you treat the cancer through the scope? Would you, I guess you could biopsy it, but what else can you do to actually treat it? Can you, I guess, coat it selectively in spots where it's apparent to treat it on a surface level? Or?
Yeah, and that is exactly what we hope to do. So if we can see a cancer in real time, right, instead of waiting for a biopsy, say your endoscope can see a 2-millimeter area that harbors a precancer or a cancer, then through that endoscope, you can put an ablative device, either cryotherapy, which is low cost, which can be used for freezing, or you can use heat, radiofrequency ablation, or you can use endoscopic snares and tools for cutting, and that area can be selectively removed. And the advantage of these low-cost microscopic devices is that it's not only a way of seeing the precancer or cancer at a more early stage, it's also a way of delineating an area of abnormality so that you can treat it through the scope. You don't need to remove the whole stomach.
So are these treatments able to, make a big impact in order, are you just removing, I guess, again, tumors in the local area, or does this require systemic treatment? Are these just like polyps or things, or like what's the morphology of what you're looking at, what you're doing?
I would say it's even earlier than a polyp. So a polyp creates a lump or bump, right, which you can see with the naked eye. You don't necessarily need a microscopic device magnifying the lining 1,000 times to see a polyp, because your eyes and my eyes could see a polyp because it's elevated. We actually want to see what happens before the polyp, the abnormal cellular changes, the tissue at a microscopic level, so we can actually treat that right away. And that can be, again, frozen, it can be burned, or it can be cut through the endoscope. Those procedures can be performed in less than an hour, and the patient can go home immediately. So no surgery, no systemic therapy, and a survival rate well above 98%.
Oh, wow. So is that the end of the situation for a lot of people, or do they continue to have to come back?
No, that's correct. That would be the end of the situation for most people. In some cases where we use heat or cold, they undergo repeat sessions of treatment every couple weeks. But once that area is treated, the vast majority of patients are cured.
Oh, that's great. Is this a new type of treatment, or has this been in existence for a while?
Well, the treatment mechanisms have been in existence for probably a little under a decade, but the diagnostic tools that we've been looking at, the microscopic devices and the portable endoscopes, those are all innovations that are coming out of work that we have been conducting at Baylor and with Rice University and their engineering team, and have taken to clinical trial worldwide. And those are not commercially available yet, but that we're hoping that eventually they will be.
Oh, how long will it be until there's commercial availability of some of these? And what's your estimation?
I think we're going to see more of these hitting direct clinical care within the next 5 to 7 years. I would say there are some comparable technologies and microscopic imaging technologies that are commercially available, but they're at a significantly higher price point, well over $9,000 and $10,000, and some of the microendoscopic platforms are above $200,000 US. We are trying to develop tools and technologies that are under $2,000. Endoscopes that cost under $100, or microscopic endoscopes that cost, $1,000 or $1,500 and can be reused. So very, very different price point we're working with.
So is there any, if someone comes to you and they're having gastro issues, let's say it's not at the stage where they can't swallow or anything, but early on, persistent heartburn, persistent regurgitation, those kinds of things. Is there anything they can do to prevent themselves possibly from having either esophageal or stomach cancer?
Yeah, that's a great question. So heartburn is very common in the U.S., right? This is a billions and billions of dollar drug industry and all the acid blocking medications. It's probably a safe estimate that over 15% of the American population experiences heartburn. Now, the problem is when that heartburn occurs regularly over a long period of time. And if that happens someone should absolutely go in to see a physician or a gastroenterologist, because it's the repeat injury from the acid into the esophagus that causes the changes that lead to Barrett's esophagus. Now, Barrett's is estimated to be in about 1 to 2% of Americans, so this is a common condition, but only a minority of those patients will ultimately go on to develop cancer.
So if someone continually has, let's say acid reflux or heartburn, is it just this repeat stimulus of those environments that cause like a maladaptation by the tissue that leads to cancers, or what do you think is the whole mechanism?
Yeah, that actually you summarized it really well. It's a maladaptation, but it is an adaptation. So the lining of the esophagus is something called squamous. That's the normal tissue of the esophagus. What happens when it sees acid reflux every day? Now, the esophagus is used to acid, but when it sees acid reflux from the stomach every single day, because the stomach is refluxing into the esophagus, patients are having regurgitation, they may have heartburn, they may have atypical symptoms such as cough or hoarseness or throat clearing. These are all symptoms of reflux. When that happens every single day over a period of years, there is a change in the cells of the esophagus, and they change from what we call a squamous epithelium, which tends to be thinner, to what we call a columnar epithelium. This is more, the cells are more elongated, and they resemble the intestine. And the rest of the GI tract is this columnar epithelium, the stomach and the small intestine, the colon. But the esophagus is not supposed to have that epithelium, but it adapts that lining when it sees acid reflux. And that lining is to some extent more impermeable to the effects of the acid, but it is absolutely maladaptive because that columnar epithelium, which is called Barrett's esophagus, is the precursor to esophageal cancer.
And what role do, for instance, like the epiglottis and the sphincter, where the entrance to the stomach or the exit from the stomach? I mean, do the sphincters get changed in these conditions? Again, I don't know if you can call it a sphincter, but the epiglottis as well, or it's just the tissue that comprises the organ itself is changed.
Yeah, so the epiglottis is higher up. That doesn't really play a role. There is a sphincter between the esophagus and the stomach, which is called the lower esophageal sphincter, and it's believed that in patients who have acid reflux, this sphincter relaxes more frequently. So effectively what happens is it's almost like a leaky valve. The door between the esophagus and the stomach tends to be open more, and that open door is what allows the acid reflux to come in.
But does it get, again, the sphincter between that at the entrance to the stomach, does that tend to get affected in any of these conditions, or is it left alone? That part of the tissue really doesn't suffer.
Well, it's more open, so to speak. So it relaxes more and it's more open. In a proportion of patients, it stays open all the time because of something called a hiatal hernia. There are a number of things that can cause that sphincter to relax or be more open. Most commonly, it's weight gain, particularly when you gain weight around the stomach. The other possibilities, it can happen during pregnancy. There are certain foods and medications that can cause the sphincter to relax more. Carbonated beverages, fizzy water, champagne, Perrier, those can cause the sphincter to open to release air, which will also often release acid reflux or stomach contents from the stomach into the esophagus. All of these things can cause the sphincter to relax, and all of those can contribute to acid reflux. Now, I want to say that it's normal for the sphincter to relax a little bit, and if your sphincter didn't relax, you wouldn't be able to burp or belch, right? And you'd be uncomfortable all the time. We all need some lower sphincter relaxation, but it's when it happens too often and there's too much acid coming into the esophagus that patients develop Barrett's.
So could something as simple as having soda every single day, multiple times a day, chronically relax your lower sphincter and perhaps predispose you to a bunch of problems?
Absolutely, yes. And actually, one of the first things I do in my patients who reflux a lot is take them off of anything with bubbles.
Yeah, interesting. Yeah, I didn't think about that. Any other usual phenomenon that the common person wouldn't know about if people are suffering with these conditions?
Yeah, I think the only thing I would note is that acid reflux is common, and oftentimes patients will tell me that they had acid reflux for years, and then they stopped feeling their reflux. In other words, they don't know where it went. Now, this can happen for two reasons. One, because they went on acid-blocking medications, but also when a patient develops Barrett's esophagus, and we know Barrett's is precancerous, I have actually found that they're less sensitive to the effects of reflux because the Barrett's lining is such that it is a little bit thicker, and it's a little bit more impervious to the effects of acid, and so just because your symptoms have disappeared or just because you're on medication doesn't mean that you may not require an endoscopy. You absolutely may.
Oh, I see what you mean. So because of the change in structure of their esophagus, they may not feel the effects of the reflux, but it's probably still happening.
It could still happen. It could still be happening, yes. And the other thing is that, if you've been taking acid-blocking medications, whether it is omeprazole or pantoprazole or lansoprazole, Pepcid, Axid, Tagamet, over a long period of time, the medications may be masking your symptoms, right? They're treating your symptoms, but you may still have some of the changes that lead to or Barrett's esophagus. So if you've been on those medications a long period of time, you should still probably be seen.
Yeah, what are some of the negative effects of common acid blockers or proton pump inhibitors in the stomach?
Yeah, so in the esophagus, of course, it reduces the effect of acid reflux and inflammation, and that's a significant advantage. These medications have been around a long time. There's some concern with what we call the PPI medications. These are the proton pump inhibitors that you mentioned, that they may be associated with bone loss because of a loss of calcium absorption, and this is probably something that does occur after a long period of time being on the medications. If you're on them for weeks or months, it's probably not an issue, but if you're on them for years, then of course bone density and osteoporosis are a concern. There's a benefit to having acid in the stomach in terms of fighting infections, and so one risk of being on these medications is that patients may be more susceptible to GI infections. I don't think this is on a day-to-day basis very clinically relevant, especially in the United States, but it's something theoretically that could be of concern. And there's some concern that these medications can interact with some of the medications that protect the heart, so that in some patients there was noted at one point to be a risk in an increased risk of heart attacks or strokes in patients who were on some of the antiplatelet therapies that were designed to protect patients from heart attacks. And that's simply because these medications would interact with those medications. So I think it's something that has to be discussed between a patient and their gastroenterologist and selectively used when needed. And I think one thing that's important to keep in mind is these medications treat the reflux. They do not treat the Barrett's or the progression to cancer. They're treating the symptoms.
Right. And, just like it seems like, carbonated beverages all the time could, again, weaken your sphincter and predispose you to reflux. What else do you think is going on that's causing reflux in people so much more often or causing heartburn?
Well, in the U.S. and the Western world, it's our diets. It's the same thing that's causing increased rates of diabetes and heart disease. It's the Western diet, weight gain, fat consumption, alcohol consumption is associated with a different type of cancer. So it's not actually alcohol in this case, but certainly it's weight gain and an increase in what we call abdominal obesity, central obesity, midline.
Okay. So looking forward, you talked about some of the new treatments that are going to be coming online hopefully soon. Any other major areas of advance that aren't as well developed but that you're excited about, you think will make a big impact?
I think we're going to see new therapies and lower cost therapies for the treatment of esophageal and gastric cancer. So we have cryotherapy devices, but there's going to be some that are even more lower cost and portable. I think our own group is working on developing endoscopes that can be used without even a power or water supply, and can be disinfected and reused and can be developed for less than $100. So this is very promising in terms of screening for it. And then I think what we're also trying to do is address the need for trained professionals to be able to look for these cancers, because you can't have expert gastroenterologists all over the world. So what we have actually tried to do is develop training apps that can be used on cell phones or augmented reality devices to teach non-gastroenterologists, either an internist or a surgeon in other parts of the world, and potentially in areas of the world where you don't have physicians available, such as rural Africa. You could have a nurse operate a portable endoscopic device and potentially use augmented reality to help with diagnosis of an abnormal area visually, or use that AR platform for a telemedicine-guided diagnosis from an expert that wouldn't necessarily be on site. So you could have somebody in Houston or in a major city guiding somebody in a rural village to diagnose an area of cancer.
Okay. Well, I wouldn't have people scoping themselves at home, but yeah.
No.
But yeah, that's great. That's great. Okay. Well, very good. Well, what's the best way for people to learn more? And, unfortunately, if they have a problem, how do they start in their journey of getting help? What's your suggestion?
Yeah, so there's a number of, papers and videos available from a lot of the GI societies, the American Gastroenterological Association and the American Society for Gastrointestinal Endoscopy. These are available online. Also, our own group, if you want to hear more about some of the tools and devices, on the Baylor College of Medicine website and Baylor Global Health, we talk about some of the work that we are doing. And, most of the work that we're doing is federally funded through the National Institutes of Health and the National Cancer Institute. So that also, if anyone is interested in learning or being on research protocols or looking at these tools and devices, those clinical trials are available.
Okay, excellent. Well, Sharmila, thank you for coming on the podcast. I appreciate your knowledge and your time.
Perfect. Thank you so much. Have a great day.
Okay.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.